Let me first start by saying that when I started BRAC, the condition of Bangladesh was so difficult and dire that one could be very depressed looking at the statistics in Bangladesh. Our per capita income was $90. Our literacy rate was less than 20%. Our health statistics, most Bangladeshis, or let's say that life expectancy at birth was 47. So, and income levels were poor, and agriculture, we used to produce 15 million tons of rice, but we needed 18 million, so therefore 3 million had to be imported from donor countries. This was the condition of Bangladesh in the wake of the civil war, the war of liberation that we fought in 1971. So Bangladesh became independent with a ruined country, with infrastructure destroyed. Schools, health facilities were non-existent. Bridges were blown off. So all these was much more difficult as a situation in a country. So when I started BRAC, this was the situation in Bangladesh. And then 10 million refugees started coming back from India into their homeland because they fled during the war of liberation. And so I thought that we will start a small program of relief and rehabilitation about 150 miles from Dhaka, a remote area where government assistance will not reach. So therefore I wanted to help a community, poor community of fishermen community in remote rural area, and started my relief and rehabilitation program. But then when you have worked in an oil company, you really don't have much experience of doing relief work. So I thought that I had to start working in relief and rehabilitation program with my own money to show that I can bring about change and I can bring about at least support for the poor people. So I started with my own money, and in course of time we found that other donors, particularly non-governmental organizations from the north, like Oxfam, came in to help me. And they provided £200,000, which was equivalent to about $500,000, to try and rehabilitate about 200 villages in about 175,000 people. So I started work with relief and rehabilitation. Then over the years, I came to realize that relief and rehabilitation is a short-term palliative. It will need long-term commitment to bring about poverty alleviation and change. And so therefore we had to commit ourselves to long-term rehabilitation program, or development program. So myself and my 200 staff that we had in 1974, we had to commit ourselves for long-term development and commit ourselves to this kind of work, of working with the poor. So we came out with a goal of poverty alleviation and empowerment of the poor as the mission of BRAC. Initially, we started with small projects to try and alleviate poverty in a small area, about 200-300 villages with a couple of 100,000 people. And we showed some improvement in agriculture, productivity, in income and employment work in that area, and also in improving health and education in a small area. And our idea was that we will be able to bring about sustainable development in these areas, and ultimately if we can show good results, it will be replicated by other people, probably by government, because we didn't have the means to scale up our program. But then we realized very quickly that nobody is going to replicate us. We have to replicate ourselves. So ourselves means that meant that we had to scale up our program in a nationwide scale. And the scaling up on a nationwide scale, a program had to be supported by large sums of money. We had to train our staff. We had to develop training capacity to be able to train large numbers of staff, management development, accounting, audit, all kinds of monitoring, all kinds of aspects were needed to scale up an organization's program to a national level. The first experience we had was in 1979. It was the International Year of the Child. And we looked at infant mortality in Bangladesh, infant and child mortality in Bangladesh. And we thought that at that time, the under 5 mortality rate of Bangladeshi children were 252 per thousand. So in other words, 25% of our children died before their 5th birthday. And we thought that if we could improve child survival, then maybe we will also have other other dividends in terms of fertility decline in our society. We also had women producing 7 children per woman. And we wanted to also, the population problem was a big problem for Bangladesh. We are a small country with a large population, and Bangladesh is still the most densely populated country in the world. So we took up a program which took us to every household in Bangladesh, trying to teach one woman in every household how to make oral rehydration fluid at home with salt, sugar and water in the right proportions, and how to identify diarrhea and to treat diarrhea with oral rehydration solution. And we did that over a period of 10 years. We went to every household and taught women how to make it. And we also taught men in the marketplace, in mosques, everywhere that we could find them, the efficacy of this particular therapy. And as a result of which, over a 10-year period, we have been able to scale up our program. Then in 1986, the Bangladesh government decided that we need to immunize our children in order to cut down infant and child mortality. And so we took up half, and the government took up the other half of the country to try and immunize all our children. And by 1990, almost the immunization rate in Bangladesh had gone up from 2% to nearly 75%. So as a result of this work, what has happened in Bangladesh is that infant and child mortality has declined dramatically since the 90s. And it has now come down to the under 5 mortality now is 64, and under 1 mortality is 52 per thousand. So they just come down from 252 to 64. So this has been a decline. And as a result of which, what has happened also is that women's fertility rate has gone down from 7 to 2.7 now. We still need to cut down fertility and mortality further. If you look at your own statistics, you will find that under 5 mortality rate in Japan is probably around between 6 and 8 per thousand. In Bangladesh, we still have 64. So there is a long way to go to provide child survival opportunities in our society. We need to achieve a lot more than what we have already achieved so far. So there is still, we are now looking at neonatal mortality, which is about 37 per thousand. In the first 1 month of life, we lose 37 children in 1,000. So that is the one that now we are trying to work on now. So we are working on maternal, neonatal and child health right now, and we are trying to bring about change in that mortality cohort.